Hello, and a very warm welcome to one and all joining with us on this lovely Friday evening, ladies and gentlemen. We have been joined by the very renowned and the very regarded Dr. N. Chandrasekhar. Sir, I welcome you on the behalf of the entire team of the World Implant Expo.
Thank you.
Ladies and gentlemen, Dr. Sekhar has trained under the aegis of American Academy of Implant Dentistry, USA, in the year 2005. He has been accredited as Associate Fellow, American Academy of Implant Dentistry, USA, in the year 2008. He has been practicing implants since 2006 and has placed over 3,000 implants, along with multiple advanced bone grafting procedures. He practices exclusively concentrating on implant-supported full mouth rehabilitations. He is presently a mentor and a speaker for Noble Biocare India Fellowship Program. And yet, another golden opportunity awaits us to learn under the fine guidance of Dr. Sekhar, as he will be adding to the value and validation of the World Implant Expo happening in Kochi later this year. Sir, it's wonderful to have you on board, and I'm sure everyone is looking forward to learning from you today.
Thank you very much, Dr. Aditi.
Thank you, sir. I think we are good to go. Meanwhile, our participants may know that they can put in any queries that they might have during the webinar in the Q&A box given below. They shall all be addressed by the master himself.
Sure.
Right, we are good to go, sir.
Shall I share screen?
Yes, sure, please.
Yes.
It's visible, sir.
Thank you, Dr. Aditi, for your wonderful introduction for me. I'm very much grateful and thankful to Smile USA Academy, DentistChannel.Online for giving me an opportunity to present my webinar on this. And before I begin, I would like to welcome you all for the forthcoming World Implant Expo Conference 2023 at Kochi from November 26 to 28. Clay Meridian, Kochi, India. We are looking forward to witness some of the galaxy of the speakers across the world, and hope we all will learn together about the failures to success and managing complications. I too am enlightened to be as a part of the program, and I'm looking forward to see you. You can see a galaxy of the speakers here who will be giving their valuable insights to our conference. Now, my topic happens to be here today is new trends and technologies in implant dentistry. Before I go, I would like to say that it's been a big amount of a journey for me too, when we started our own implant dentistry career, starting from with the periapical x-rays, models, diagnostic casts. And to say in the past, probably 5 to 10 years, we have witnessed a remarkable change in the trends and technologies which have been evolved in this implant dentistry. So we started the journey with beginning with end in mind. Initially, when we were trained, we were looking at all those ideal cases to place implants in a predictable way. And then it's a simple way of doing a single tooth implant by placing a regular abutment and then a cement retained crown. For a period of time, then we started working towards more about screw retained crowns, especially in both in the anterior and posterior sections, of course, in full mouth rehabilitations too. And if you see, all those screw retained crowns would give you a better emergence profile and better aesthetics. So looking forward, what we initially started with is like a simple clinical pictures, periapical radiographs, panoramic graphs, and then models. It's like a working models on which we used to measure the distances, both mesodistal and buccolingual and so on. And then we used to have these bone calipers clinically to measure the width of the soft tissue, unlike what we have today with more amount of CBCT and the other technologies. It has become very easy, but initially it was more about a ridge mapping, both clinically, like how you see here, where we used to measure the bone width with the help of the reamers, perioprobes, by giving a small local infiltration, or in the laboratory side, Or in the laboratory side, we used to do even ridge mapping on the models too, to evaluate what is the remaining amount of a bone which is available. And then it was a simple case. And apart from that, guides and all have come now. But in those early days, it was more with the help of a simple vacuum formed stent and regular acrylic stents. We used to give these we used to deliver implants. Now, second stage surgery to deliver, to uncover this implant and placing healing collars. We were taught to follow all these steps very meticulously, especially when we are doing in AAD Maxi codes, that all those cars have to be mounted on an articulator to evaluate what is the future restorative course, future restorative phases we have. And we used to do a wax up. We used to have a simple flippers also few times to evaluate how your future restorations come. And these are the few, few types of stents we used to have them, where on a simple working model, just arrange 2 or 3, acrylic teeth and then fabricate a clear acrylic stents. And you try to place your drills through those acrylic stents. And then we started working on them closely with careful analysis and execution. You could see that there are a good amount of cases where it is being placed meticulously. For example, in this case, if you see, you would be able to see those are subcrustally placed. It's more about to add value onto the restorative space rather than anything else. Because if the space happens to be a little constrained by working on our models, if you see the model, the restorative space is less, and even a screw retained crown becomes difficulty. You need to little submerge them to gain the restorative space. So continuously, when you follow those principles, whatever we've been taught, you tend to see all those cases in a beautiful way without any hazard. But if someone hasn't followed those steps, before I start this, I'm like want to say that apart from the clinical side, I own a lab called as a Precise Dental Lab, where we used to receive a lot of prosthetic cases from the implants, where we used to witness cases something like this, where the planning and the execution was completely different. And when you see these implants placed, we used to diagnose them, how mesodistally or labiolingually the implant is positioned, and how to rehabilitate these type of cases without any difficulty. But to say, first and foremost important thing is that we are not supposed to do cases something like this. We have to work on a restorative driven implant dentistry in all the parameters. In this case, it looks as if the implant is positioned absolutely fine, but when you see on a frontal side, you tend to see the implant is positioned somewhere at the spine. So if you look at the restorative space, if you look at the vertical cantilever, and if you look at the long sulcus, all those parameters would definitely jeopardize the implant there. So we just have to compare whether they are prosthetically driven or not. Something like this, where there is no diagnosis. It was almost like darting. It was almost like a darting where the implants are placed haphazardly without any issue. Apart from that, there are situations where even when the implants are placed properly, if the restorative space analysis is not done properly, you will end up in picture something like, because there are specific guidelines for restorations in a specific condition. If you have space, for example, around 8 to 10 millimeters, you are supposed to have a particular type of restoration. You have more than that, you have. So there is something called as a restorative space analysis, which we have to work on so that we can decide what type of prosthesis is ideal in that particular situation. You tend to see a lot of acrylic fractures, especially when there is insufficient restorative space. Clinicians say that usually we do it because of the finances, but that's not the reason we have to think about it. What we need to think is what is ideal case, ideal process for that particular condition. And if you see something like this, where the implants are very closely placed, because doctor happens to say that it is inaccessible, it is not possible, that's not the question at all. We have to decide what would be the best way to do all these things. If you see cantilevers, inter-implant distance, even if the impression is right or wrong, in these cases, it becomes difficult to analyze. Of course, once we started working on, CBCT, which has come, it has become a little more easier than earlier when we used to do all the cases with periapicals and OPGs. But in regular case stream or a Newton software, you can definitely analyze virtual planning. You would be able to see the width of the bone. You will be able to see the height of the bone. You would be able to see the vital structures which are near to it. But when you do all those things, it is only a virtual plannings that are done, but they don't end up in a good ideal placements. If you look at this particular case, it looks as if on a panoramic X-ray, it looks ideally placed mesiodistal, but in a three-dimensional way, you will be able to evaluate that the implant is almost perforating the labial cortical plate. Most of us, when we look back our own cases, call the patients back and try to analyze where there may be a haze discoloration or a metallic discoloration in the soft tissue, then you would realize that there is something wrong which has happened while placing it. So in few other instances, before I tell something like this, whatever the new trends and technologies have evolved, I would say that we have to classify them as diagnostic, surgical, and restorative. There are advances which have come in diagnostic, there are advances which have come in surgical, and there are advances which have come in restorative. Now, again, in restorative, you have both on a clinical side, new trends and technologies, and laboratory sides also new trends. And looking at this particular picture, if you see that the implants are placed perfect, but there was an excessive torque while placing. Why? The cause happens to be they are not able to understand the bone biology. That is, when we evaluate the CBCT, we are supposed to look not only on the dimensions, but also the quality of the bone. And the newer softwares, newer virtual planning softwares, all those things will give you an exact view, exact idea about the density of the bone, whether the bone is D1, D2, D3, D4. And accordingly, you should be able to understand what is my correct RPM, correct torque, whether I need to do any densification of the bone can be evaluated beforehand. In a situation like this where they've been placed implants properly, post-operatively, it looks okay. But over a period of time, you can see that there is a full amount of a bone loss associated on the entire periphery of the implant. It is more about not able to understand what is the density of the bone, what are the drills, osteotomy we are supposed to place in those dense type of bone. And any excessive torque would definitely lead something like this, where the bone viable cells around these implant sites tend to necrose and cause a failure, leading to not only failure, but lot amount of a bone loss. You see this case? So I am very much a big follower of this Madam Jill Helms from Stanford University, who has done a wonderful studies all through her career. She's from Stanford University. We need to follow her all the articles and videos which are there. This is from FOR. You can see the understanding of the biology of osseointegration. Okay, now comes, there are different softwares which have come, which plays a crucial role in evaluating how we can place implants in which direction and all. And then you can have from the present scenario where your intraoral scan and CBCT can be combined. You don't need to match up them with an artificial intelligence. Automatically, the both gets attached to itself. And then wherever the missing teeth are there, you can be able to place your virtual teeth to see how your implant trajectory is in relation to the future tooth. You can just see how it looks like when you make all those changes. And most of the times you see all the armamentarium, all the types of implant brands you have, so that you can ideally select from there and place them and virtually see whether your implant is in a right direction or not. And in few instances, a few softwares provide you such a way that you can change your workspace by just a click. You just click one particular thing, you see a panoramic workspace, and you click another one, you can see a cross-sectional, where you can view your virtual planning in almost all sections. Apart from that, the main value of any good software, the planning software, is it gives you an indication of your bone density. For example, in this particular software, you can see that once you move around, you will be able to evaluate what is the density in relation to this. Somewhere it is 1480, somewhere it is 1670. So you will understand, depending on the bone density, you can control your RPM, you can control your torque, and you will be knowing whether you can densify the bone if the bone happens to be less dense. So these will give, especially in a situations like all-on-4, where patients are already mentioned that they are aware that you will give an immediate teeth setup. Now you can't go back and tell your bone happens to be less dense and I can't afford to give you a immediate teeth setup. Now, because now in these softwares, they provide all these values, you know exactly how this goes. And then when you know that the density of the bone happens to be changing, then you can alter your RPM and then get your primary stability properly so that you can deliver your immediate prosthesis. And apart from that, they give a lot of implant brand selection and their 3D position in relation to the adjacent teeth. If you see a classical case, these are the classical case which you come out. But most of the times in maxillary anterior region, what we need to know is, especially in terms of a three-dimensional positioning of the implant, we need to exactly know whether our future implant position is in relation to the adjacent cement-enamel junction around 2 to 3 millimeters, whatever Dennis Starno's principle have, whether it is being followed. So the software will provide you enough knowledge, enough information. It provides enough information where exactly you have to place your crest of the implant so that you get a beautiful emergence profile. If you look at these two slices, you would be able to evaluate whether this particular case is for a socket shield or a partial extraction therapy, where you have a very thin bone, and when you extract, there may be a chance of a dehiscence. On another hand, you have a solid cortical plate where you can think about a regular extraction and implant place. So these are the good diagnostic information which these current softwares provide, and subsequently the success of those implants also will increase. So in terms of mesodistal single implant, I don't really need to mention all those things. It's just like 1.5 mm from the adjacent teeth on each side. But at the same time, the main important thing is the 3 mm superior to the same CEG of the adjacent teeth, something like that. But this can happen only if you plan exactly in the virtual software. And then you will be able to establish a picture like this, where it is exactly 3 millimeters, and you see a beautiful emergence profile just because the implant is exactly positioned where it is supposed to be. And then labiolingual positions are also properly placed so that your screw access hole is completely palatal. So apart from that, these softwares also provide you different types of abutments which are available. In a full arch situations, you tend to see there are so many abutments which are available, and those inventory of those abutments are available from the softwares. You just have to select from those range of the products and then see which abutment is, so that all that inventory is beforehand on your chair before executing your case. You can just want to know a straight multi-unit abutment or a 30-degree or a 17-degree, whether you need to have a collar length of 3.5 or 4.5. Everything is predicted beforehand so that you don't have any confusion while you are placing your implants or other inventory. So then we started working from the regular implantology to a guided surgery, where initially it started with a static guided surgery. And those cases, when you do it in a proper way, both you have new technologies, both static guides and dynamic guides. But to say first, in case of a static guides, this is how a static guide is fabricated with the help of those. Earlier, what I mentioned was more about planning, but it is more important that it's not only about the planning, but also the execution of the case is more important, for which we need these aids like a guided stent and guided drills to execute the way it is being planned. So in few of these situations, you really don't need to, do a flap also. It can be done flapless. Patient will have a very less amount of a post-operative discomfort. So when you place implants and then reanalyze whatever the planning which has been done, whatever the guide which has provided, whether it has provided you a good way to perform your surgery or not. So when you start evaluating them with the help of a post CBCT, you can be able to see whether the implant is three-dimensionally positioned correct or wrong. That is a best way to do analyze both maxilla, mandible. In relation to mandible, you can see how well it is positioned within the contours of the bone with the help of the simple static guide. And then you have softwares which help you to analyze how the comparison of your virtual plan planning is done with the help of a post CBCT. There are algorithms which help you to understand if you superimpose your post CBCT on the virtual planning, you will be able to evaluate how good or how bad your implants are positioned in relation to. It can provide you those differences, deviations, which can analyze, which can evaluate for future corrections, whether the guide is properly seated or not, whether the implants are perfectly positioned or not. Some advanced cases, if you see in these type of cases, especially maxillary anterior, we can't afford to do any sort of a mistake, like how I've shown those slides where the implants are perforated through the labial cortical plate rather than an incisal edge or so. So those type of restorative catastrophes has to be avoided. It can be avoided by a simple means of using these simple guides, which are static guides. So you can do on your own. You can just send it to a lab where they can perform all these things. They do a virtual teeth placement and they will send you a report showing how these virtual teeth are in relation to antagonists, in relation to the future implant trajectories. And once it is there, it is our responsibility as a clinician to evaluate the fitting of those guides on the working cast before we start working on the patient. So you need to check how good the static guide is in relation to the working cast. And then when you start placing them clinically inside the patient's mouth, and then you perform your surgery, and then you see that the accurate three-dimensional positioning of the implant, post CBCT clearly give. See, this is how we need to work on employing those new technologies which are available. And then these are very important, especially if you see a case like this, where there is a labial concavity and there is some amount of a bone which has been resolved already. So an young boy, where you want to have your future emergence profile, like exactly how it goes to. So the planning is absolutely done in the software, and then looking at all those Tarnos principles, the implant is positioned exactly 3 millimeters below the CEJ of the adjacent teeth. And intentionally, those implants in this case are exposed, because we are not supposed to place them inside the bone, because it would leave a lot amount of a long sulcus or a junctional long epithelium. So which will not provide you a good emergence profile. So these softwares will provide you the exact position of those implants. And then subsequently, you have so many techniques where you can use your GBR or some other amount of a block graphs. You can use them, utilize them, and then do a right way of doing implants, especially in the maxillary anterior region. Then close it with your PRF membrane. And then again, you check that. Now you see the amount of a bone graft which is being placed on the labial side, so that you will have a beautiful contour when the patient comes back 6 to 8 months later. And in a cross section, you tend to see your implant is exactly at that position where your access hole is coming palatally. In a similar way, you tend to see a more good amount of cases where you can do these things, whether it is 2 implants, 3 implants, 4 implants. You can do it with the help of these static guides. You can perform your guided, you can perform your GBR and membrane tags subsequently. But the simple difference between these static guides is, these are on one side, you see the regular drills, on the other side, you see a guide. We need to understand the concepts and philosophy of guided stents before we handle them, because the regular drills are little shorter than your guided drills. So the troubleshooting sometimes comes where you can have a ill-fitting surgical guides. The guided drills are too long. So if the patient doesn't have a mouth opening properly, you may not be able to do a surgery. So you need to understand these concepts beforehand before you perform guided. If the mouth opening is restricted, especially in posterior regions, and if you are doing an Alon 4 where the implant has to be positioned at an angle, it becomes difficult in this type of situation. There are some other modifications, of course, available in guides where there is something called as a C type of a sleeve where you can position your sleeve from side, but still that amount of a drill is definitely around 9 to 10 millimeters longer than a regular surgical drill. So we need to have a separate surgical guide kit for our static guides and other accessories like spoons and all. And we have to understand the concepts of these offset and prolongation in guided surgery. And apart from that, in this condition, you can't change the plan in the middle of the surgery. And you need to have both internal and external irrigation whenever you are performing implant surgery with the help of static guides, because it's like a blind procedure. The irrigant is not going to reach the tip of the drill. So until and unless you have internal irrigation, it is not possible, and sometimes there may be an excessive heat generated at the tip of the drill. Now dynamic guides, they are like same day you plan and execute. You decide, and even if you want to change, you want to make any modifications, you can do. Same day computer assisted surgery, there is no guide which is needed. You can plan virtually, validate the report exactly whether it is in relation to that or not. If you look at this particular case, these are routine cases which will come up. But commonly when you see a trajectory like this, and on a panoramic X-ray, it looks as if you have an abundant amount of a bone volume. But on a cross section, when you see, it looks as if it is an offset to your implant position. So the ideal position of the implant in relation to the future tooth is almost at the buccal end. If you just follow the trajectory of the bone, the implant is almost like a scissor bite for the antagonist. So you can't afford to do all those that type of a surgery in this type of a cases. So in navigational guide, you will just have something like a patient tracker and a handpiece tracker. It delivers a real time. That means when you are looking at the monitor, you will be able to see the real time tracking 360 degrees of your drill. During that, you can stop in the middle, you can change the angulations. The workflow is available both for partial and fully edentulous indications. Now, if you see, there is a free hand. The second one happens to be with the help of a surgical templates, and third one happens to be with the help of a dynamic surgical navigation. Now, if you see how it works, you will have a screen on a monitor which will show you where your handpiece drill is exactly in relation to the virtual planning what you have done. You can select your implant dimensions according to it. You can change them, whatever. Every modification is possible with the help of this dynamic navigation. If you see a case, something like this, as I said, maxillary anterior region, you just can never afford to have any leeway. No freedom, no chance of error in this situation. Virtual planning, which has been done with the help of a planning software. And when you see back with the post CBCT, you can be able to see exactly how the implant is positioned three-dimensionally within the contours of the bone. Probably if I would have done it in a freehand, maybe it's not, I may not be able to deliver this amount of a precision when I compare with a dynamic navigation, which is like a real-time precision. You can just see here. Yeah, when I do a three-dimensional view of this implant position, you'll be able to see that 360 degrees, all the three dimensions of the implant has been predictably accurately placed the way it is being planned. This is how it looks like when you are doing it. It's like you just have to watch the monitor rather than looking at the patient plan. And it's the same surgical drills. You don't need to change any drills. You have the same surgical kit what is available from the company. Once it reaches its desired length, it will give you a green signal there, and that's how it looks like. So once you just look at the post CT, again, you will be able to evaluate exactly how they look like. Good evening. Here we now post CBCT clearly shows how this implant is three-dimensionally positioned. 3, 6. And let's see. Just want to scroll it down. The implantation-based implant surgery deviation. So this is how the situation is in the case of typical anatomy where there is a good amount of a myloid undercut. And if you look at when you place your virtual teeth in position, your ideal implant position is somewhere here in relation to your future teeth. You can't afford to place implants in the bone trajectory which is available. And then just tend to see how three-dimensionally you can be able to evaluate the virtual planning which is there. And on the teeth set which is there, the exact dimensions. And again, if you closely observe, it's the same scenario where the implant threads are exposed intentionally because the implant is positioned prosthetically in a proper way. So whatever the remaining threads are there, it is being grafted with a GBR. And you can see the post CBCT, how it shows exactly the amount of a GBR which is positioned in relation to all the exposed threads. What is ideal here is the ideal three-dimensional positioning of the implant for the future restorative phase. And all the cross-section shows exactly if you closely observe in this case here also, in a normal way, you would tend to perforate your lingual cortical plate. But in this case, it doesn't happen. It just goes and sit where it is determined. So this is how a post-op picture OPG shows. And it works very efficiently, and it works in all kinds of situations, single implant, multiple implants, even in situations like an all-on-4 is done, virtual planning is done in BPX, and then execution is done in the navigational unit. And just to have a comparison, you can be able to see how those implants exactly are positioned from the virtual planning to the execution. And you know that those implants are going in this way, and you can deliver your immediate processes without any issue. In a similar way, you have a case. This is called as a patient EDX tracker. In place, there are different trackers which are available. Right. Let's stop.
So the video is paused.
Paused. My slides are also not going up.
It's okay, sir. You can unshare and reshare again. They'll work.
Sorry for that.
No issues, sir. We were having such a good time
Thank you.
looking at your presentation.
One second.
Are you able to do it, sir?
Just a second. Just a second. I think somehow it got. Some of my windows got stuck here. Sorry, you're wonderful.
Sir, you're not audible as well.
Right.
Okay, no, sorry. I'm sorry. You're audible.
Where am I can share my screen now. Can you
Yes.
see?
Yes, sir, it's visible.
Thank you. So this is a case, and then post-op, you can see the placements in relation to that. We have used is especially when the nerve is very closer to your shorter implants, it gives you a lot of a leeway in understanding that, and then deliver the processes immediately within no period of time. And you can just exactly see where your implant positions exactly. Prosthetically, it has been decided that to avoid mandibular fracture, your implant should be in such a way that you don't leave any cantilever also in relation to this. And it's not about that adapting technology. You need to look at the scientific validation also. And if you see this Journal of Oral Implantology, and then they have done a lot of research on that, and then what they realized is that the angular accuracy of these implants when delivered using the tester device is just like 0.89 to 0.35 for dentate case types. And in relation to a completely edentulous situations, the margin of error is just 1 to 1.5 degrees. And that's how it has become an accurate method for placing implants in a predictable way. There's a lot of literature which shows, and thank you for your attention. I hope I am within the time.
Thank you
That's all.
so much. Yeah, thank you so much, sir. It was wonderful listening to you, and we learned how important it is to have a holistic approach while placing implants for rehabilitation. And it was a much needed technology driven session that we have been long waiting for. Thank you so much, sir. Shall we take up some questions?
Yes, sure.
Yes. So, first of all, how long should one wait after a GBR procedure to load the implant?
We just need at least 6 to 8 months for the healing period to happen. And it all depends on what type of graft you have placed. Okay. In terms of an allograft, and usually the combination, what commonly we use is a combination of allograft and xenograft along with PRF, so that there is good amount of a time for the xenografts to resolve. So around 6 to 8 months later, you can definitely afford to load.
Okay, all right, sir. Then, sir, another question says that how many implants can be done in each arch? And also, Dr. Subir wishes that if you could brief about sinus implants.
I just missed that. There was a lag in the connection.
Okay, so the question is that how many implants can be placed in each arch?
See, it all depends on the arch perimeter, but on an average, around 6 to 8 implants in the maxilla, 5 to 6 implants in the mandible in a regular axial way is sufficient enough. But all-on-4 is a different philosophy when you compare with an axial implant. You can't compare them. Even though 4 implants are predictable, good enough, but that is not a panacea that we need to understand. So the regular implantology of axial implants, if you look at 6 to 8 implants in the maxilla and 5 to 6 implants in the mandible are good enough to support.
All right, sir. So, and can you please brief our audience about sinus implants?
Sinus implants.
Yeah, like for example, we have a low sinus lining. So, how do we go ahead in that case?
There are good number of people who have done a long journey in relation to the implant placement, especially when the residual bone height is less. The first one happens to be an open method, that is a direct sinus lift, and the other one happens to be an indirect sinus lift. Now, if the residual bone is anywhere from 2 to 4 millimeters, at least less than 4 millimeters, you can definitely go ahead with your indirect sinus lift. But if the residual bone height happens to be less than 2 millimeters, we would suggest to go for a direct sinus lift until and unless the clinician has an enormous amount of an expertise in performing indirect sinus lift, even when the residual bone volume is 2. But according to the literature, less than 4 millimeters is ideal to go for. More than 4 millimeters ideal to go for indirect, less than 2 millimeters ideal to go for a direct sinus lifts.
Okay, understood, sir. I hope it answers the questions of our audience. And so, thirdly, can you please suggest any software or like the software that you use?
There are a good number of softwares which are available. From Nobel, it is called as a DTX Implant Studio. There is another software from San Francisco called as Guide Mia. And real software is from Zimmer. Almost all these softwares are good. Of course, even Blue Sky Bio is good enough to, and it is free of cost, basically. Only thing is, any software you take, it's based on STL. So the moment you click your STL, you are being charged. So it's a good one to go ahead with all these DTX. You have Guide Mia, you have Real Guide, you have Blue Sky Bio. All these softwares are good enough.
Okay. So does it take special like training to operate these, or these are handy?
Actually, yes, but being all the members of AAD, for us, I don't know. We have been fortunate enough to learn on our own. We are very been, but of course, there are the software whoever are providing. They provide online teaching for you to understand the concepts of these softwares. But once you start working on it, you should be able to understand each and everything.
Okay, so thank you so much.
Technology has given us so much. Even like at this age, we are not an younger generation like you people, but we have to compete with those people. So we started working on these technology-based apps, and then it's working well.
Yeah, so we are so fortunate.
YouTube videos and online software trainings in relation to them.
Right. So we are so fortunate to have torchbearers like you, leading the path for us. So we are lucky to have you. So the next question is, can you brief about immediate implant placement, please?
Yeah. Immediate implants are considered when your residual implant has lost its good amount of a tooth structure, not to support your regular restoration. It should be devoid of any infection, and it should have a three-dimensional view of your bone around the tooth. Apart from that, you have immediate implants both in anterior section and posterior section. In relation to anterior section, if you have an available bone at least 2 to 3 millimeters beyond the apex of the implant, you are good to go if there is no periapical infection. Okay, but the most important aspect of any immediate implant is how atraumatically you are removing your residual tooth. If you are not able to manage the tooth extraction atraumatically, it becomes a disaster. You will end up in complexity of the cases more. Now again, in immediate implant, in relation to the anterior, if the implant is properly positioned three-dimensionally, once you engage your apical 2 to 3 millimeters above the thing, if you have a good stability, you need to look at three-dimensionally. If the 5 to 2 millimeters, you can just avoid.
I'm sorry, sir. Can you please pardon? There was a connection glitch in between.
So once the implant is placed, if you, my internet connect, am I audible?
Yes, sir. Yes.
Once the implant is positioned, taking all these parameters into consideration, you need to check if the implant has got any amount of a jumping distance. The jumping distance is that gap from the labial surface of the implant to the labial cortical plate. If the distance happen to be less than 1.5 to 3 millimeters, you can just leave it like that, allow the blood to clot, form a clot, and then mature. But if the gap happens to be more than 1.5 millimeters, it's ideal that you pack the jumping distance with some amount of a graft material, which enables the implant to have a stability, and that jumping distance is closed. Whereas in relation to the posterior teeth, again, it is more important how atraumatically you remove. Almost all the mandibular or maxillary posteriors, when you are trying to do extraction, you have to split them with the help of roots. You have to split mesial and distal roots separately and remove each one at a time, so that your interradicular bone is preserved. If you try to remove the tooth en masse, there is always a possibility that either a labial cortical plate or your interradicular bone is. People think that even if it is lost, I can place my implant in the mesial socket or a distal socket. Biomechanically, it is the most unfavorable. So you need to preserve the bone interradicular so that you can place your implant exactly in the center. So there also, again, if most of the times, of course, recently we have watched Dr. Varun giving a beautiful classical video showing how around 6 to 7 millimeters width of the implant is ideal in situations like immediate extractions of the posterior teeth. You can follow that and then place the implant in such a way that at least buccal and lingual cortical plates are engaged for the primary stability. And then just close with the graft material and close it. That's how the immediate implant is.
Right. Thank you, sir. Thank you for being so patient with the doubts. Sir, we mentioned, like you mentioned during your presentation, one of the cases where an extra torque was provided than what the bone could bear. So what can be the management in such cases?
See, in a situation what I've showed, if you see on one side, there is a clear case of a picture where one part of the one side of the implant has got a necrosis of it. So coincidentally, it happened in such a way that when I went for a second stage surgery, then I realized that there is some amount of a sinus coming out of it. So when we started opening up and then see that there are a good amount of threads which are exposed on the mesial surface of the implant. And when we used not the common method of managing these types is you need to use some plastic scalers not to damage any of the implant threads. So you have to debride all the necrotic tissue whatever has happened in relation to the around the implant, and then try to evaluate, like how in perio they say it's whether it is a 1-wall defect, 2-wall, 3-wall. So if it happens to be a 3-wall defect, it's a good to go because you have 3 walls around which will enable the blood circulation to flow if you are doing a bone graft. So once this tissue is being debrided and ensure that the socket or the site is very clean, you just try to use some sort of antimicrobial solutions like a gentamicin or a tetracycline powder, apply it onto the surface of the implant, make it sanitized for a few minutes, and once it is then cleanse it off, then use your graft material. The graft material, again, what we realized is it's better to use a synthetic graft materials in these type of cases, where you don't enhance the microbial culture of those with the help of these xenografts and allografts. So it's ideal to use the synthetic graft materials to keep it there, pack it there, and leave it like that, and then slowly you can tend to see that. But there are a good amount of literature which shows even when you place your allografts in relation to that, they have matured into the host bone. So the ideal way of looking at is whether the implant surrounding, so the defect surrounding the implant is 1-wall, 2-wall, or 3-wall. If it happens to be a 1-wall, you can't afford to do anything other than explantation of the implant.
Right, understood.
And common xenografts or membranes which commonly used, there is a question there, which shows like the xenografts can be from a different brands. You have a Krios from Noble Biocare, and you have the from Zimmer also, exactly don't remember. Xenogain from again Noble. With Xenoprotect is another collagen membrane in relation to this. BioOS, you have both BioOS and BioGuide from Geislich. So these are the standard graft materials which we are supposed to use. Any sort of a material which is of a mediocre quality is not going to work. After some period of time, when you open up and see, it looks like a chunk of a plaster block. It's not like a host bone. So you need to use these materials in a predictable way.
Okay, all right, sir. Thank you so much for such a wonderful session. And it certainly takes a great deal of experience and expertise to deliver the kind of precise work that you delivered. So thank you so much. We were, honored to have you on board today. So one last concluding message from your side to the clinicians willing to attend the World Implant Expo.
Thank you, Dr. Aditi, for giving me this opportunity. I would like to extend a warm welcome to all the participants and the delegates all over here who would like to witness a galaxy of the speakers, as I mentioned earlier, that the World Implant Expo at Kochi from November 26 to 28th would give you the amount of an insight for all the types of complications on a day-to-day basis which we are encountering. So converting implant failure to success, managing complication. And believe me, it is not like this is one particular topic which is interested. Every particular topic has been chosen in such a meticulous way. As I said, implant dentistry has to be categorized as diagnostic, surgical, and restorative. And all the lectures which are posted in this particular conference will completely entail all these type of a classification from diagnostic, surgical, restorative. Of course, in both clinical and laboratory sides, you will tend to see all the troubleshooting type of things and learn a lot from all these fine speakers. I would welcome all people, looking forward to see you there.
Thank you so much, sir. We look forward to learning from you in Kochi this year. Thank you so much for joining with us and sharing your invaluable insights. And have a good day, sir. Thank you so much.